Usually when we talk about practicing medicine, there's this expectation of absolute certainty. Like you see a symptom, you prescribe a pill, and the patient is cured. It feels like it should just be binary,
Yeah.
clean.
Right, which is a comforting illusion. I mean, we really want human health to be perfectly categorizable, kind of like an engineer looking at a blueprint.
Yeah, exactly.
Hmm.
But then you step into the real world of clinical medicine, and suddenly that blueprint is, well, it's missing half its pages.
Hmm.
It is just completely murky
Oh, absolutely.
because you can't just memorize a textbook of facts to treat the patient sitting right in front of you. You actually have to understand how those facts were discovered in the first place,
Hmm.
right? And whether the math holding them up is even reliable.
Yeah, if you don't fully understand the origin of your evidence, you don't really know your evidence at all. It's the very definition of diagnostic muddy waters.
Which is exactly why we are taking this deep dive today. For all of you listening out there, whether you're a medical student furiously prepping for the USMLE or, a young professional just stepping into the clinic, or even a self-taught learner, we are unpacking the foundational language of medicine today.
We really are.
And our guide for this journey is the 4th edition of High-Yield Biostatistics, Epidemiology, and Public Health by Dr. Anthony N. Glaser.
It is such an indispensable source because, well, it strips away all that abstract noise. It distills incredibly dense mathematical concepts into the actual practical tools that physicians are forced to rely on every single day.
Yeah, so we're going to trace the entire life cycle of medical evidence today. We'll start with how we measure raw data, move into how we actually test hypotheses, explore how medical studies are designed, and then apply those numbers to diagnosing you, the individual patient.
And finally, zooming all the way out to track diseases across entire populations.
Right. And, while biostatistics can sometimes be dismissed as this dry math requirement, it is actually the ultimate medical detective tool. I mean, it is the literal difference between guessing a treatment works and mathematically knowing it saves lives.
Absolutely. And any good detective has to fundamentally understand the nature of their evidence before they even start analyzing it, right? So in biostatistics, all raw data falls into one of 4 specific scales of measurement.
Okay.
The book uses this great mnemonic, NOIR, so that's nominal, ordinal, interval, and ratio.
So the first two feel fairly intuitive to me. Nominal data is just qualitative categories, right? Like there's no inherent order, male or female, blood type, healthy or sick.
Exactly.
And then ordinal data introduces a meaningful ranking, so like a student's class rank or the staging of a cancer, even as the gap between rank 1 and 2 isn't exactly the same as between 2 and 3.
Right. The problem really arises when we move to the I-interval scale data. This is where clinical researchers, frankly, often make mathematical mistakes.
I'll admit, interval data always trip me up because it feels like it should just be ratio data. Like it have a meaningful order and equal intervals. Take Celsius temperature, for example.
Right, temperature's a classic one.
The difference between 40 degrees and 50 degrees is the exact same amount of heat as the difference between 90 and 100 degrees. But that lack of a true absolute zero completely changes the math you could apply to it.
It does. The clinical math is completely restricted there because 0 degrees Celsius doesn't actually signify a total absence of heat, right? So you mathematically cannot say that 40 degrees is twice as hot as 20 degrees. The ratios just don't work.
Which pushes us directly to the R, ratio scale data.
Yes. And most critical biomedical variables land right here: weight, pulse rate, blood pressure. Because a pulse of 0 means an absolute lack of a heartbeat.
A true zero.
Exactly. And because that absolute 0 anchors the scale, you can finally make meaningful clinical ratios. So a heart rate of 120 beats per minute is mathematically precisely twice as fast as 60 beats per minute. You literally cannot run certain statistical tests if you miscategorize these data types at the start.
Wow, okay. So once we have our data correctly categorized, if we pull the fasting glucose levels of, 200 patients, we map it. And we all know the standard Gaussian bell curve and the measures of central tendency, right? The mean, the median, and the mode.
The classics.
Yeah, but relying heavily on the mean in a clinical setting feels like a massive trap if the data is skewed.
Oh, it's highly sensitive to extreme outliers. It'll pull the entire average violently up or down.
I always picture it like putting a billionaire in a room full of broke medical students.
That's a perfect analogy.
Right. The average or the mean net worth of the room instantly shoots into the tens of millions. But the median, the student standing dead center in the lineup, is still eating instant ramen. The median is totally blind to that extreme wealth.
Yes, that is a textbook, positively skewed distribution. The median only cares about how many data points are above and below it. It completely ignores their actual values.
Which raises an obvious question, right? Like, if the median is vastly safer from outliers, why does medical research lean so heavily on the mean?
Well, the mean provides a structural anchor that research desperately needs. So if you draw repeated samples from the exact same population, the mean will fluctuate significantly less from sample to sample than the median or the mode will.
Oh, interesting.
Yeah, it resists fluctuation, so that makes it incredibly stable for long-term clinical research.
Okay, an anchor makes sense, but the center doesn't tell the whole story. Like, I could have two patient groups with an average blood pressure of 120, but in group A, everyone is hovering right around 120, and in group B, half the patients are crashing at 80 and the other half are, stroking out at 160.
Right, and that's where variability comes in. Variability is the missing puzzle piece. To understand that spread, we rely on variance and standard deviation. And rather than getting bogged down in all the formulas, you really just need to know that standard deviation maps how tightly the data clusters around the mean.
Got it.
For any normal bell curve, clinical reality is essentially governed by the 68, 95, 99.7 rule.
Okay, meaning 68% of patients will fall within one standard deviation of the mean, 95% will fall within two standard deviations, and 99.7% will fall within three standard deviations.
Exactly, so you instantly know where almost every single patient sits relative to the pack.
But, and I'm guessing here's the hurdle researchers face, we're only ever looking at a tiny sample. Like, we have our little N sample data, but we can't measure the blood pressure of every single human on Earth, right? The big N population.
Right, we have to somehow bridge that gap between our sample and the entire world.
And we cross that bridge using hypothesis testing. So whenever a new medical study is launched, it starts with a baseline assumption that the intervention, say, a new drug, does absolutely nothing.
Yeah.
The null hypothesis.
Yes. The assumption of no difference, no effect, and no relationship.
I always conceptualize this as like a criminal trial.
Oh, how so?
Well, the null hypothesis is basically innocent until proven guilty.
Yeah.
The drug is presumed completely ineffective unless our data provides overwhelming, undeniable evidence to convict it of actually working, which is the alternative hypothesis.
That's a great way to look at it. And the stakes in that scientific trial are massive because the jury can make two distinct types of devastating errors. A type I error, also known as an alpha error, is a false positive.
So that's like convicting an innocent person. We conclude the drug works, but the data just looked good by pure chance.
Exactly. And the real-world consequence there is putting a useless drug on the market, exposing millions of patients to side effects and financial strain for literally zero clinical benefit.
Yep.
Yeah, and the inverse is a type 2 error, a beta error, which is a false negative.
So letting a guilty person go free, the drug actually does work, but our study sample was perhaps too small to catch the effect, so we abandon a potential cure entirely.
Precisely.
The book actually highlights a fantastic mnemonic for medical board exams to keep these straight. IAs and two beans.
Right. So type I alpha errors accept the alternative hypothesis wrongly, IAs, and type 2 beta errors accept the null hypothesis wrongly, 2 beans.
Two beans, I love that. So we know how to manage those errors mathematically. But how do we actually gather the patients to run this trial? Because randomized controlled trials, or RCTs, they're considered the gold standard since you deliberately manipulate the variable like. Giving half the group the drug and half a placebo in randomization strips away all those confounding background factors.
Sure, but randomized controlled trials aren't always practically or ethically possible.
Right. Like, if I suspect a chemical exposure causes cancer, I obviously can't randomly assign 500 healthy people to drink it for 10 years.
No, the ethics board would shut that down immediately.
Thank goodness.
So that constraint forces us to rely on observational studies, where nature basically takes its course and researchers simply watch. And the two heavyweight designs in observational research are cohort studies and case control studies.
Okay, so cohort studies take a healthy group, note their exposures, like diet, smoking, environment, and then follow them forward in time to see who gets sick. Like the book highlights the Framingham Heart Study, right?
Yes, exactly.
Started in 1949 by tracking over 5,000 healthy people in Massachusetts for decades to uncover the risk factors for heart disease.
Right, and because cohort studies track people forward in time, they are prospective. This allows researchers to establish absolute risk and incidence. You can definitively prove that the exposure happened before the disease.
But they are agonizingly slow,
Right.
right? Like, they cost a fortune. And if you are studying a really rare disease that only strikes, say, 1 in 50,000 people, you'd have to follow millions of healthy people for decades just to get a handful of sick patients to evaluate.
Exactly, which is why case control studies solve that exact logistical nightmare by moving retrospectively. So, you start with the outcome. You gather a group of patients who already have the rare disease, those are your cases.
Okay.
Then you gather a similar group of healthy people, your controls, and you look backward into their histories to see if a specific exposure was overwhelmingly common in the cases compared to the controls.
Ah, okay. So a cohort study is like looking out the windshield as you drive into the future, waiting to see who gets sick.
Yeah.
But a case control study is looking in the rearview mirror to see where the sick people came from.
That's spot on. And the efficiency of looking in that rearview mirror is staggering. The book details a classic 1971 study linking maternal exposure to the drug DES with a rare vaginal carcinoma in young women.
Oh, wow.
Yeah, they didn't need millions of subjects.
Uh,
They established the definitive link using just 8 cases and 32 matched controls by simply checking the mother's pregnancy histories. It was fast, inexpensive, and life-saving.
that's incredible. Okay, so now let's apply this massive infrastructure to the actual person sitting in the exam room. We've proven a diagnostic test is both valid, meaning it is accurate to reality, and reliable, meaning it is repeatable and precise. We also know the test's sensitivity and specificity.
Right, the classic SNU and spin mnemonics.
Yep.
So SNU stands for a highly sensitive test with a negative result rules OUT, the disease. Sensitivity basically measures the test's ability to catch everyone who actually has the disease, which minimizes false negatives.
And SPIN stands for a highly specific test with a positive result rules in the disease. Because specificity measures the test's ability to correctly clear the healthy people, minimizing false positives. But here is where my clinical intuition completely collapses. I have a major issue with how these percentages actually feel in practice.
Ah, you are walking into the trap of predictive values.
Okay, because if a test is 90% sensitive and 99% specific, it sounds mathematically bulletproof, right? Like, if a patient gets a positive result, I feel like I should be able to look them in the eye and say with near certainty that they have the disease.
You'd think so, but the math tells a wildly different story. The positive predictive value, which is the actual percentage of positive tests that are real, is tethered entirely to the prevalence of the disease in the specific population you are testing.
Right.
The book gives this brilliant diabetes screening example that proves just how dangerous this assumption is.
Walk us through the numbers because this completely shifts how you practice clinic.
Okay, so take that exact test, 90% sensitive, 99% specific, into a high-risk inner-city clinic where 20% of the population has diabetes. So out of 1,000 people, 200 are sick.
Okay.
The test catches 180 of them. And out of the 800 healthy people, the 99% specificity means it correctly clears 792, but it drops 8 false positives.
Okay, wait, let me track that. We have 180 true positives and 8 false positives. So out of all the positive results, about 96% are real. So in that clinic, a positive test means a 96% chance the patient is actually sick. Those are solid odds.
They are. But now, take that identical test to a low-risk clinic in a different neighborhood where only 2% of the population has diabetes.
Oh boy.
Out of 1,000 people, only 20 are sick. The test catches 18. But you have 980 healthy people. The 99% specificity still drops 10 false positives.
Wow. Okay, so we only have 18 true positives, but we have 10 false positives.
Exactly. The positive predictive value has plummeted to 64%. More than 1 in 3 positive results in this clinic are completely fake. You are using the exact same test, but because the disease is rare in this population, a positive result becomes dangerously unreliable.
That is wild. You just cannot blindly order panels for rare diseases in healthy populations because the false positives will absolutely drown out the true positives. You have to understand the underlying health of the community first.
Exactly. Which forces us to zoom all the way out to population health and epidemiology, because tracking disease dynamics relies on separating incidence from prevalence.
The epidemiologist's bathtub model from the sources is just brilliant for visualizing this. Picture a bathtub, right? The water flowing out of the faucet into the tub is incidence. The absolute risk, the new cases happening right now in a specific time period. The water level sitting in the tub is prevalence, total existing cases at any given moment.
Right, and water only leaves that tub in 2 ways. It goes down the drain, which represents mortality, or it evaporates, which represents recovery and cure.
So apply that to a chronic condition like Alzheimer's. There is currently no cure, meaning there is zero evaporation happening. But if medical advances keep Alzheimer's patients alive much longer, we are essentially plugging up the drain.
Yes. So if the faucet flow, the incidence stays steady, but the drain is plugged and there is no evaporation, the water level rises. Prevalence skyrockets, not because the disease is actually spreading faster, but simply because people are living longer with it.
It perfectly proves that a high prevalence doesn't always equal a raging epidemic. Sometimes it just means modern medicine is successfully delaying mortality.
Exactly. Now, when the faucet does turn on full blast, epidemiologists track the outbreak using epidemic curves, basically histograms charting cases over time. A single sharp peak that rapidly declines suggests a common point source epidemic, like, say, a contaminated batch of food at a banquet.
Okay.
But progressively higher peaks suggest a propagated person-to-person spread.
And tracking that spread doesn't necessarily require a microscope, right? Like Dr. John Snow proved this in 1854 during that terrifying London cholera outbreak. And bacteria hadn't even been definitively proven to cause disease yet.
No, they hadn't. But he mapped the location of every single case, noticing a massive, undeniable cluster around one public water source, the Broad Street Pump.
Oh.
He also noted that brewery workers in the same area who only drank private well water were completely spared. So he figured out the transmission vector entirely through data mapping, and he stopped the outbreak just by removing the pump handle.
He didn't even know what cholera was, but he knew exactly how it operated. And that is the true power of this evidence-based toolkit. I mean, we've categorized NOI data, we mapped the bell curve, avoided convicting innocent drugs in hypothesis testing, compared the windshield of cohort studies to the rearview mirror of case control studies, navigated the mathematical landmines of predictive values, and tracked epidemics with the bathtub model.
It's quite a journey. And to ensure these concepts really stick, particularly for the medical students using this deep dive as a study guide, consider this short scenario based on everything we've covered today.
Right, let's hear it.
Imagine you develop a highly effective new drug that completely cures a chronic disease within a matter of weeks. However, the rate of new people contracting the disease in your community remains unchanged. What happens to the incidence and the prevalence of that disease?
Oh, that's a perfect stress test for the bathtub analogy.
Yep.
Okay, so if the rate of new people contracting it stays the same, the water coming from the faucet hasn't changed, so incidence remains exactly the same. But because your new drug is curing people rapidly, you have essentially turned up the heat. The evaporation rate in our bathtub has skyrocketed. People are leaving the sick population fast. Therefore, the overall water level drops and prevalence drastically decreases.
Spot on. It's a crucial dynamic for public health planning. The incidence remains steady, but the prevalence plummets.
We have covered a staggering amount of ground today, but before we close this deep dive, there is one final, really provocative concept from Dr. Glazer's book that I want you all to just mull over. It ties all the way back to our very first point about the illusion of perfect certainty.
Yes, the statistical definition of a normal lab result.
Right. Think about the normal range for a cholesterol panel, or liver enzymes, or a white blood cell count. In statistics, the normal range is strictly defined as the middle 95% of a healthy population. The math absolutely dictates it. But if the normal range is just the middle 95%, that mathematically guarantees that 5% of perfectly healthy, totally normal people will be flagged as abnormal on any given test, just because they sit at the edges of the bell curve.
Yep.
It is an unavoidable byproduct of standard deviation.
So for you listening, as you step into the clinic and order a comprehensive panel of 20 or 30 different lab tests for a patient, what are the mathematical odds that every single one of those tests comes back in the normal range? If 5% of healthy results are flagged as abnormal, the more tests you run, the more likely you are to find an abnormality in a perfectly healthy person.
Exactly.
So when you see a jagged line on a test result, ask yourself, are you actually finding a disease? Or are you just hunting for that statistical 5% of natural human variation? The diagnostic machinery isn't perfectly clean. You have to be the one to interpret the shadows.